How is healthcare policy promoting or hindering advanced care planning? That's the topic Judy Paris addressed during her presentation at Conversations at the Crossroads, the 2013 Joan Berkley Bioethics Symposium. Paris is a clinical social worker with postgraduate training in cognitive behavioral therapy and mind-body health. She has extensive experience in stress management, grief work, aging, and palliative care. Her career spans 3 decades and involves both Medicare and Medicaid health policy experience as well as clinical work. Judy, thank you so much for taking the time to join us on the Bioethics channel. Welcome.
Thank you. Thank you for having me.
To start out with, I'd like to talk a little bit about the presentation that you made this morning. What are the societal perspectives related to death and dying that you think are most important for us to be looking at this point?
Well, John and Myra gave me a large range to look at in terms of looking at societal perspectives that are, I would say, inhibiting our ability to really have an honest and frank conversation about end-of-life care or what we want near the end of life. And what I looked at really is both the public policy, the clinical, organizational issues that are keeping us from really moving forward in advanced care planning the way that we would all have hoped after having worked on these issues some 40 years.
One of the things that I was very interested in that you dealt with at the beginning of your talk was this whole idea of what the history of end-of-life care has been. Can you describe what things were like in the 1900s, where we are now, and where we should be going?
One of the things I found that's fascinating when you look at it, and so that we don't sort of reinvent the wheel along the way, is that we've changed so much in how we've approached death. It used to be part of life. Grandma used to be laid out in the dining room. We died suddenly at the turn of the last century. Life expectancy was until 46 years old, as opposed to now where we're living frail and longer. And we didn't hide death. It was just part of living. And what happened as we got more technologically sophisticated, we ended up what I like to call over-medicalizing death, and we've hidden it. The movements in these last 40 years, whether it was hospice or the Patient Self-Determination Act, which the center was instrumental in helping bring forward, have helped try and change that dialogue again, but we have not yet actually gone back to where we were in the 1900s in terms of caring for our loved ones.
What are the challenges and the issues that we need to be thinking about as we're looking at providing quality end-of-life care?
Aside from our own fear of mortality, so this is not a topic that people like to approach, and so a lot of what we've tried to advance is not necessarily the way the public wants to hear it. Sometimes it gets mixed up with rationing discussions, such as the death panels and that sort of thing. We also have organizational challenges that we have to overcome and health policy issues. We have an acute care system that is not really pitched towards taking care of the needs of the whole person and what the kinds of care that a person needs near the end of life, whether that's 6 weeks, 6 months, or 6 years towards the end of life. We need a constellation of social services, meals, transportation, help, chore-making services, not ICUs and machines and the extraordinary efforts that are needed at the end when it's not warranted.
There seems to me to be kind of a confusion about some of the lingo that we use, long-term care versus palliative care. Can you clarify the language and
try.
and also describe the palliative care model that you talked about?
Sure. You know, when you talk about language, and this is something I hadn't even mentioned in my speech, which is really a concern for some of us in the way that we're talking about care near the end of life, is that people have started to call it advanced illness care, serious illness. Even some of the hospices are moving hospice out of their name. So it's a hard road to try and get people to talk about this. What happened along the way is that the palliative care movement came in around 97 or so, which is a type of care that hospice delivers. It looks at the whole person and their family. It's what we call biopsychosocial care. Peter Whitehouse spoke today as well, talking about it being eco-psychosocial care, so it has a sort of a moving even further away from just the medical model. But the palliative care looks at comfort and symptom management and a holistic view of what a person needs, not just this acute care, sort of machines, tube feeding, that sort of thing.
What are the current trends and challenges that you see in palliative care?
One of the things that we have to look at when we talk about palliative care and how it grew up and how it coexists right now with what we call long-term care, which is currently in Washington being called long-term services and supports, and also this new move towards chronic care and chronic conditions, which is another name that has come in vogue in the last decade or so, is that these three systems of care don't exactly work well together. And the money goes to this acute care side. And even with the Affordable Care Act, although well-meaning and looking at how do we coordinate care for people across different provider types, whether it's nursing homes, home health, hospital, it still is not looking at the constellation of services that a person needs with palliative care or long-term services and supports. Sometimes having that kind of care in the home could keep persons from coming in and out of the hospital in a way that's really not serving them well.
You mentioned a recent study that indicated, unfortunately, things haven't progressed as much as we might have hoped they would have in the area of end-of-life care. Can you give me a brief synopsis of the study and the takeaways we should have from it?
I was almost disheartened when I saw that. As I was preparing for coming here to the center, I noticed that it was just April 1st in JAMA. There had been a small study, 12 hospitals in Canada, and they were looking at whether there was concordance with people's wishes at their end of life with their advance directives. And only 30.2% of the people that died had their wishes followed, which seems like after 40 years of work on this issue, a little bit of a low example. I was just sort of actually surprised that it was that low. Only 11% of the people, when they expressed their wishes, said that they wanted life-prolonging care. So people are having the conversation, want to have the conversation, have their preferences and wishes, and they're not being followed. That I found very sort of disheartening in a way. And whether it's that the interventions are not right, or people just don't want to talk about it, or that we don't have a system where it's built in as a default, is, I think, some of the challenges for the future.
What are things that we can and should be doing to try to change things for the better?
There's some really simple organizational and health policy pieces that I think are sort of the kind of thing only a policy wonk could love, but simple things that people are not even aware of, like our electronic health record system that is starting to come on board. They don't even have a checkoff box in that electronic health record for if you have an advanced care plan or not. And that we should be having a controversy at this late date as to whether that should be a box to be checked off or not seems to be odd. Now, even if that was there, it doesn't mean anybody's wishes would be followed, but it would be at least good if it was there. In the VA system, they have an electronic system that if you're looking to close out a case at the end of the day, if the person's record comes up and they don't have an advanced record on file, you can't shut that record out. So there's certain odd little organizational things that can be done that would help make it be the default, and we don't have that right now.
From your vantage point, what's the importance of Medicare and Medicaid policy in improving end-of-life care?
When we think about the fact that 2.5 million people die each year and 83% of them are Medicare beneficiaries, this is a Medicare issue. Now, Medicare, based on an acute care model from the 60s, is moving itself slowly into recognizing that the Medicare population, as they grow older and frailer, is a population that needs more coordinated care, different types of care than just hospital care, but they still don't have that full array of psychosocial services that is what's really needed as we move into frailty near the end of life. And although there's great strides being made with the Affordable Care Act, we still don't have that companion of the social service side in there.
And that kind of leads directly into the next thing that I wanted to address. What real opportunities are presented by the Affordable Care Act? What do we need to be pushing for?
I think as community advocates become more aware of what's in the Affordable Care Act, they can, in a certain sense, organically work with some of these new programs that are showing up and be insistent that there be social work included, or that they have the conversation with their physicians. On the one hand, there are some work that's being done with accountable care organizations, community care transition programs that are trying to keep people from being readmitted to the hospital. And so the movement is in the right direction, they just don't have all the right players in place yet. And so this is to be unfolding in these next 3-4 years. And so someone at the local level, as the patient-centered medical home comes in, as an accountable care organization comes in, as these community care transition programs come in, if they advocate for what people really need, these are opportunities to put that in place.
One of the things that the Affordable Care Act brought up is this whole issue of death panels. You brought up in your presentation that we should actually want to have the death panel talk. Can you elaborate on that? Why should we have that conversation?
Because I think if people started to embrace death still as part of living, more like we were at the turn of the last century, where it was, although none of us want to die and we all want to stay around with our loved ones, it is part of the life cycle. And if we look at that as part of a natural cycle of life, then we could have the conversation in an honest way, and it wouldn't be about rationing health care. It would be what about is best for us towards the end, and what would keep us healthier and happier so that you would be living well at the end of life. And so I say that because we had a report to Congress on advanced care planning that was coming out a month before the whole death panel discussion, and that has taken hold of the public in such a way that I feel like you need something almost as bold as calling it the death panels to counterbalance the forces that think of it as rationing healthcare, which it's not.
From your perspective, why has it been so difficult for us to have the conversations surrounding this issue, and especially when you look at studies that show we haven't made all that much progress in 40 years? Right. What do we need to be doing so that 40 years from now we're not in the same place grinding away trying to figure out how to make improvements?
I believe we need to build it into our system. I'm not sure that just having these conversations or trying to promote the conversations is exactly what's going to happen to change. We have to, as I said, when we brought in end-stage renal disease in Medicare and we mandated that a social worker be at the table, there's a social worker at the table. As many other programs in Medicare has come in and they're not mandating their social worker there, there's no social worker there. Not that the social worker is going to be the one that helps the people have the conversation, but if you mandate that the conversation be had, the system provides it. And so I think that's got to be one of the ways that we make the change happen. That plus grassroots.
Judy, thank you so much for joining us. Judy Paris is a licensed clinical social worker and expert specializing in long-term care and end-of-life care policy. Thanks for tuning into the Bioethics channel. I'm Anna Jaffe with the Center for Practical Bioethics.